Welcome. I'm Bob Ferris. I'm joined by Ezra Cohen and Quinn Lee, an all-star cast of panelists here. So thank you for joining us for this educational symposium entitled Understanding the Impact of Immunotherapy and Head and Neck Cancer, a look at the science, practice, and future of multimodal treatment. And this is truly multimodal. I'm a surgeon. We have medical and radiation oncologists, and all three of us are immunotherapists. I'm at the University of Pittsburgh Hillman Cancer Center in Pittsburgh, Pennsylvania. And joining me is Dr. Ezra Cohen at the University of California, San Diego, some local talent here in La Jolla, and Dr. Quinn Lee, who is Chair of Radiation Oncology at Stanford University.
The following audio is part of a certified educational activity. Access the entire activity and complete the post-test at www.peerview.com/RBS. Downloadable slides and practice aids are also available.
We're in a phenomenal time. We've spent decades really maximizing the ability to mix and match radiation, surgery, chemotherapy in different combinations, in different sequences, in different intensities. But now, as you see, we have a fourth modality with FDA-approved agents targeting PD-1 and some very promising agents targeting PD-L1. And this has led to a completely different viewpoint. Obviously, the interest here in the audience focused on how to integrate targeted immunotherapy and what is the science underlying it. So as of September 2017, which is actually almost over, just a few more days left, we have two FDA-approved agents, pembrolizumab and nivolumab, both targeting targeting PD-1, the receptor, for recurrent metastatic head and neck cancer with a disease progression on or after a platinum-containing chemotherapy. We have a large number of phase 3 trials, some that have been completed in the first-line setting, nivolumab, pembrolizumab, and durvalumab, with or without combinations targeting another immune checkpoint, CTLA-4, which combine with ipilimumab or tremelimumab. And these first-line trials are completing or have been completed, and I think in the near future, we will hear the data read out, hopefully in the next 12 months or so. But the goal tonight is to think about beyond recurrent metastatic disease and moving immune checkpoint therapies into standard locally advanced treatment. Multiple studies of immune checkpoint inhibitors and locally advanced head and neck cancer are ongoing. We will discuss these tonight in the concurrent chemoradiation, so-called organ preservation setting, as well as the postoperative and in some cases preoperative neoadjuvant setting. And so using different modes of integration of immunotherapy may have different science and rationale behind it, and I will leave that to my colleagues here on the panel to describe the data. As many of you know, as a new agent would come out over the past 10 to 20 years, even including genomically targeted therapy, what we saw was an increase by a couple months here or there in a recurrent metastatic population. But the promise of immunotherapy was the durability and the immune memory, which the adaptive immune component permits. And the data which we'll share with you tonight and review, I imagine many of you have seen some of the initial data, is that durability actually does exist and long-term responses may persist. The question is, how do we move this small incremental benefit, as promising as it is, which has led to the new FDA-approved agents, into the locally advanced setting? And how do we take this benefit and enhance survival in a larger group of patients who can be cured? So tonight's agenda is to bring you up to date for the evidence related to immunotherapy in head and neck cancer, from single agent to combination studies, including immune IO combinations. We'll actually have a wonderful treat for you, a video of one patient's journey, his experience through standard therapy and eventually onto immune checkpoint therapy through a clinical trial, and he'll give you that directly on the screens. And then Dr. Lee will explain how to integrate immune checkpoint therapy with radiotherapy as a modality partnering with IO, and what is the evidence and practical issues to consider.
So what I am going to talk about for the next 20 minutes or so are really mostly the data that already exists around immunotherapy and specifically checkpoint inhibition in head and neck cancer. And then we'll explore what the future may hold, both in the near term and possibly the long term. We've learned a lot about the molecular biology of squamous cell carcinoma of the head and neck, especially over the last few years. We've begun to understand that molecularly there are two distinct subtypes of head and neck cancer, one caused primarily by tobacco as a carcinogen and one caused primarily by a virus called human papillomavirus. We've come to understand that although we can group them, really every single cancer is its own entity at a molecular level. We've also, and in the context of immunotherapy, begun to understand that squamous cell carcinoma of the head and neck, for the most part, is a moderately mutated tumor when we look at mutational load, and that's exactly what this graph shows you. So on the y-axis is mutations per megabase pair, and on the x-axis, data taken from TCGA. Each patient is represented individually, and you can see that there are some with relatively high mutational loads, but most patients with head and neck cancer, including those with HPV-positive head and neck cancer, have a moderate to even a modest mutational load. That becomes important when we think about immunotherapy, as I'll talk to you about in a few moments. But we also know one other unique aspect of head and neck cancer, in that most patients, especially with HPV-positive disease, as shown in these figures, express a ligand called PD-L1, which of course many of you are familiar with, in its receptor, or the other side of that synapse, PD-1. We've also learned about the immune landscape in squamous cell carcinoma of the head and neck, and we've begun to understand that it is highly, in many patients, immunosuppressive. In this case, looking at T-cell infiltration in both HPV positive and HPV negative, but also the level of T regulatory cells and NK cells, and showing that these have prognostic implications. And then data from our group that was published late last year demonstrating that from the sense of macrophages and the immunosuppressive phenotype that some of these cells can take on, not only is it common in head and neck cancer, in fact, most of the macrophages, if not all of the macrophages we see in these tumors, are the so-called immunosuppressive or M2 phenotype, but that has a dramatic implication in prognosis, as you see here in HPV-positive head and neck cancer, and incidentally in almost every cancer that we looked at across the TCGA database. So a modest mutational load, a immunosuppressive microenvironment that often expresses PD-L1, especially in HPV-positive cancers. And so that sets the stage for the utility of anti-PD-1 or PD-L1 antibodies in this disease. And what we have noticed is essentially reproducible single-agent activity. And let's keep in mind, in a disease where, despite prior attempts of immunotherapy, everything had failed. And so when we began to see responses of these single agents blocking one synapse or one ligand receptor system in the immune system, demonstrating sometimes dramatic responses, I think many of us, not Bob, but many of us were quite surprised and intrigued. Let's go over those data. The first set emerged using a drug called pembrolizumab in the so-called KEYNOTE-12 trial, which was essentially an expansion of a phase 1 study in recurrent or metastatic squamous cell carcinoma of the head and neck. Here's the waterfall plot. The y-axis represents the change in tumor size, each patient on the study represented by a single bar. And what you can see is that almost half the patients enjoyed some reduction in tumor size, with some of them enjoying dramatic reductions in tumor size. Here's the spider plot that plotted, again, every patient as an individual line, and you can see the change in tumor size. And those patients that have those dramatic near complete or complete responses, looks like they go a fairly long time. This is still early, measured in weeks, but even some patients with stable disease enjoying also prolonged, durable disease stabilization or disease remission. Further evidence was provided by the KEYNOTE-55 study, now a select cohort of patients who were refractory to both cetuximab and platinum in the recurrent metastatic setting. And what you see is a response rate of 16% overall, and in both HPV positive and HPV negative patients. Here is the same type of plot in KEYNOTE-55, really illustrating the same thing, that these deep responses can be very durable. Here the x-axis is measured in months. I don't want you to think that it's only anti-PD-1. We have single agent data now with anti-PD-L1. In this case, I'm showing you durvalumab. These were data presented about a year ago at ESMO. And again, the same sort of theme emerges, single agent responses with targeting this receptor ligand system. And so, of course, when we see that, and especially this idea that some of them may be quite durable, we went into phase 3 studies. And the first phase 3 trial compared nivolumab, again an anti-PD-1 antibody, to standard therapy in platinum refractory squamous cell carcinoma of the head and neck. And I'll draw your attention to the fact that these patients were allowed to have progression after curative intent therapy as long as that occurred within 6 months of completing that therapy, and that therapy included a platinum. So in a sense, a mix of first-line patients who had recurred early after receiving curative intent therapy, and second-line patients who had received a therapy in the recurrent metastatic setting and now unfortunately had progressed. And they were randomized in a 2-to-1 fashion to receive nivolumab versus methotrexate, docetaxel, or cetuximab, and lo and behold, the study was positive. And I would say dramatically positive when we think about what chemotherapy or even cetuximab has done in this disease in the past. Incidentally, this was the first positive randomized trial in second-line or platinum refractory squamous cell carcinoma of the head and neck, and not by a small margin, doubling 1-year survival from 18% to 34%, which was preserved at the 18-month follow-up, with a hazard ratio of 0.71. The nice other aspect of this to report is that these agents tend to be fairly well tolerated. Quinn's going to talk a little bit more about the toxicity, so I won't belabor the specifics, but I'll draw your attention to the first row, grade 3 or 4, so serious toxicity occurring in 13% of the nivolumab-treated patients, while 35% of the investigator's choice chemotherapy or cetuximab. So not only more efficacious, but also better tolerated. And here we see the select adverse events reflecting that the toxicities with nivolumab tend to be immune-related, as you might guess. We're trying to activate the immune system. Unfortunately, in some patients, we activate it against their normal tissue. If you were watching the durvalumab studies, you got a hint of this. But the other theme that has emerged is that PD-L1 tracks with efficacy. Here you see in CheckMate 141 split by PD-L1 expression at the 1% level. So in other words, the tumor had to express some level of PD-L1. It couldn't be 0. And what you see is an exaggeration of the benefit. Hazard ratio now of 0.55. Remember, the hazard ratio for the trial overall was about 0.7. In the PD-L1 negative, there's a hint that later on something emerges. At the very least, they do no worse than chemotherapy, and that's one of the reasons that PD-L1 testing is not part of the use of these agents in head and neck cancer as opposed to some other diseases, because in PD-L1 positives, there seems to be a dramatic benefit. Even in PD-L1 negatives, it certainly is not worse than standard chemotherapy, and remember, better tolerated. The P16 status is interesting, at least in CheckMate 141, there seems to be some additional benefit to the P16 positive patient, but that's a story that still is emerging and needs to be written. And as you might guess, now there's another phase 3 trial with data, and this is the so-called KEYNOTE-40 trial comparing a similar anti-PD-1 antibody, this time pembrolizumab that you heard about a little bit earlier, and again to the familiar methotrexate, docetaxel, or cetuximab, again in patients who had platinum refractory disease in either post-curative intent setting or who had received platinum as recurrent metastatic disease therapy, 495 patients, most of them treated in a 1-to-1 randomization. And what's interesting to note is that on the pembrolizumab arm, at the time of the report, and this report was literally just 2 weeks ago, there were still 22 patients on study, with one having completed the pre-specified 2 years of pembrolizumab, while only 2 were ongoing on the standard of care arm. And what you can see here is a emergence of a difference between the 2 arms, with one important caveat, that the statistical analysis for this trial required a hazard ratio of 0.8 for us to call this positive, and actually the hazard ratio is 0.81. So despite a p-value of 0.02, this is technically, statistically, not a positive trial. Although I would argue to you that with a difference in median survival, and perhaps more importantly, a difference in 1-year survival going from 27% to 37%, that these data are indeed clinically meaningful and really underscore what we know about anti-PD-1 in recurrent or metastatic head and neck cancer. And once again, looking at the populations that express PD-L1 in their tumor, what we see is a greater benefit at a cutoff of, this is not a percentage, it's a composite score, but a fairly low cutoff of PD-L1 expression. We see 1-year survivals going from 26% to 40%. But lo and behold, when we use the cutoff that is approved in non-small cell lung cancer first line, an expression score of 50%, we now go from 25% to 46%. And I'll show you the response data in just a minute. Here's the forest plots from that trial. We can see that some groups may have enjoyed a greater benefit than others, but for the most part, the confidence intervals do cross each other. And here's what I was getting at with the response rate. With a TPS greater than 50%, remember, we're talking about recurrent or metastatic squamous cell carcinoma of the head and neck that is platinum refractory, and we're seeing a 25% response rate, with some of those responses being complete. I won't belabor this other than to say that the median duration of response on pembrolizumab, 18 months. Patients who responded enjoyed a response on average of 1.5 years. We don't see that with chemotherapy, median response 5 months. And again, this idea that immunotherapy might work even in patients in the 3rd line. So when we track subsequent therapy on patients receiving pembrolizumab versus standard of care, we see that about 12% of these patients on standard of care arm went on to receive immunotherapy. I can tell you that almost every single one, in fact 30 of the 31, involved a checkpoint of either PD-1 or PD-L1. And when we look at their survival, these are patients who had platinum, tumors progressed, had methotrexate, docetaxel, cetuximab, tumors progressed, went on to receive immunotherapy, and this is the top bar. Their median overall survival, 20 months. Now, this is uncontrolled, they're clearly selected patients, but there's this sense that these patients may indeed be benefiting. When we censor for these patients at the time of receiving immunotherapy, we begin to see a better hazard ratio in favor of pembrolizumab, suggesting that perhaps subsequent therapy may have influenced the intent to treat analysis. And the same story about toxicity, generally well tolerated. What I wanted to highlight here is the immune-related adverse event that we see in squamous cell carcinoma of the head and neck that is greater than any other malignancy is hypothyroidism. And that may be related to the fact that many of these patients had their thyroid radiated during curative intent therapy, but here about 15%, with one patient having actually grade 3 hypothyroidism. So it's something in our head and neck patients we need to be mindful of. So those are the data that exist today for immunotherapy in squamous cell carcinoma of the head and neck, at least as far as PD-1, PD-L1. Where are we going next? And one of the directions, of course, is combination immunotherapy, these so-called IO treatments. And some of the emerging data that we've seen started with using an anti-PD-1 antibody, in this case nivolumab, with an anti-KIR antibody. KIR primarily expressed on NK cells, although some other immune cells, including T regulatory cells, can express it. By blocking this receptor, which is a negative regulator of NK function, the hypothesis was that it could potentiate the activity of an anti-PD-1 antibody, which of course works primarily, although not exclusively, on cytotoxic T cells. And lo and behold, what we saw was indeed there may be additivity, if not more than that, in this population. So here we see 26 patients in this cohort, and what we can see is that some of these patients had profound responses, higher than we would expect to see with nivolumab alone, with 5 of these patients near CR or CRs. And here the spider plot, and I'll draw your attention to these patients that appear to have very deep responses that also appear to be quite durable. And the overall response rate, 25%, comparing at least numerically favorably to nivolumab alone. But the story doesn't stop there, of course. Now we have other data combining an IDO inhibitor with anti-PD-1 with the premise that this enzyme, IDO1, is highly immunosuppressive, converting tryptophan to kynurenine and other metabolites that seem to influence the immune suppressive microenvironment in a way that we don't want. And so, of course, inhibiting this enzyme appears to have a immune stimulatory effect, primarily, but not exclusively, again, by affecting T regulatory cells. And here again, the combination data, this time with pembrolizumab, an anti-PD-1 antibody, with an expansion cohort in patients with head and neck cancer. And what we see is, again, that same story of perhaps a higher response rate, 34% overall, 38 patients treated. But if you look at patients in the first or second line, so the ones that weren't heavily pretreated, a 39% response rate with 10% complete responses. Again, showing you the waterfall plots with some patients with complete responses and what appears to be the emergence of durable response rates in some PD-L1 negative patients, but mostly PD-L1 positive patients, but in both HPV positive and HPV negative patients. Also well tolerated when combined. Here you see the ADs of special interest, which are really immune related, and we see a 13% severe toxicity rate, which was the exact number that we saw with both nivolumab and pembrolizumab alone, suggesting that we can add an agent, we can get better efficacy, but without increasing toxicity. Suggestion, uncontrolled trials, but certainly something to watch out for going forward. And then lastly, the combination that I want to leave off with was presented just recently again at this year's ESMO a couple of weeks ago, using a STAT3 inhibitor in combination with the same idea, a checkpoint, this time an anti-PD-L1 antibody called durvalumab. The science here would suggest that STAT3 is an important mediator of myeloid-derived suppressor cells. And again, we know, as I told you at the beginning of the talk, that the tumor microenvironment is highly immunosuppressive in squamous cell carcinoma of the head and neck. So if we can possibly activate T cells with anti-PD-1 or PD-L1 and then combat the immunosuppressive microenvironment with KIR or IDO, or in this case, STAT3, maybe we can potentiate the activity. Again, this is an expansion type of study going from phase 1 to a part B, which in this case was called phase 2, in multiple cohorts of both patients that were naive to PD-1 or patients who had been pre-treated. I'm going to focus on this cohort, B3, patients who were naive to anti-PD-1 or PD-L1, who now were receiving the combination of durvalumab and a STAT3 inhibitor. And what we see in this cohort of patients, small numbers, 28 patients, 3 complete responses, 5 partial responses, for a response rate of 30%. And again, there are patients who are having dramatic responses to these drugs that appear to be durable. The study still needs to mature, but the idea that there are some patients who are really benefiting from this combination. Interestingly enough, that seemed to be across PD-L1 expression, from even low expressors having responses to high expressors, the same thing, with a manageable toxicity profile. We do see an increase in liver enzyme in some patients. This is an oligonucleotide STAT3 inhibitor, and of course these are metabolized in the livers. And we do see predictably some thrombocytopenia, both of these being reversible. And so what are the major studies that are now combining immunotherapies? And these are my last few slides. As you can guess, We have gone into the phase 3 setting with combinations. Bob alluded to it. Interestingly enough, the combination that is in phase 3 has actually not been tested in phase 2 in squamous cell carcinoma of the head and neck. Having said that, the combination of an anti-PD-1 or PD-L1 and an anti-CTLA-4 has demonstrated activity in multiple other tumor types, first melanoma, but now non-small cell lung cancer, small cell lung cancer, and most recently renal cell carcinoma, showing a benefit in overall survival. And so with that in mind, several groups have taken this combination of anti-PD-L1 and anti-CTLA-4 into the randomized trial setting. This is actually not a randomized trial, but this is a large phase 2 study called Condor that has yet to report. This is the phase 3 trial, the so-called EAGLE study, that now compares standard of care, in this case being the same single agent choices, to durvalumab monotherapy or durvalumab tremelimumab. Those data have yet to report. This is the first-line trial, the same combination. Here you see durvalumab, tremelimumab. The control arm is the extreme regimen of platinum 5-FU cetuximab, and there's a durvalumab single-agent arm. Not to be left out, pembrolizumab has a phase 3 study in this space as well. Again, first-line recurrent metastatic head and neck cancer. Standard comparator is the extreme regimen. But here, interestingly, a little bit of a different approach. There is a pembrolizumab single agent, but in this case, pembrolizumab now combined with chemotherapy, with some encouraging data again emerging in other tumor types, especially non-small cell lung cancer, that we may get utility from combining anti-PD-1 with our standard chemotherapy agents. And then lastly, the CheckMate 651 study that compares, again, the control arm extreme to nivolumab and ipilimumab, PD-1, CTLA-4. Single agent anti-PD-L1 is active, anti-PD-1 as well, and effective in squamous cell carcinoma of the head and neck. We now have approval in the United States for 2 of these drugs, pembrolizumab and nivolumab. Combinations targeting immunosuppressive tumor microenvironment appears promising. We have examples of IDO inhibition, anti-KIR, and now STAT3 inhibition. Many more combinations capitalizing on other mechanisms are moving forward. In fact, there is not enough time. We'd be here for a couple of days if we went over every single study. And that phase 3 trials in first line recurrent metastatic head and neck cancer have completed or are near completion, and we will see results probably within the next 12 months. So look out for those very exciting times in head and neck cancer.
This is a video provided courtesy of the AACR in collaboration with the Head and Neck Cancer Alliance.
When the doctor called, I was at work. I went to the back room and took about a half hour to get myself together. And it just felt like my world just stopped. Everything else outside of that just seemed to keep rolling. My name is Bill. I'm 54 years old. I do large-scale computer repair. I've been doing it for 35 years. Back in 2013, about a week before Thanksgiving, I went into the bathroom in the morning to shave and put my head back, and I noticed a little lump on my neck. And the wife says, "You better go get that checked out." So I went to the doctor, and they sent me to an ear, nose, and throat, got a scan, and did a biopsy. Came back, and they said it was squamous cell carcinoma. So it was about a couple days before Christmas, I went in for a procedure so they could find the source of my cancer. They found it in my left tonsil, and they came back and said it was caused by HPV. So that was a total shock to me. I'd never heard, like, what's HPV? My first treatment was radiation for 6 weeks, twice on Fridays, and I also got a drug called cetuximab. Cetuximab made me break out real bad, and like these little pimple things that are very itchy here on my face, real bad in my hair, and the radiation caused blisters inside my throat. So after about 4 radiation treatments, I couldn't eat anymore. So I lived on boost, 7 boosts a day for 3.5 months. That's the only thing I had. Get up in the morning, boost in the morning, all day long. So yeah, it was rough. Lost 25 pounds. About 3 months after my initial treatment was my first CAT scan. Went in, Doctor says, everything looks great, looks great. It was a Friday afternoon. So we were like, yahoo, yahoo. On Monday, I got a call from the doctor saying, we found a 6 millimeter spot on your one lung. Don't worry about it. Could be anything. So I went back in 3 months and got the bad news. She says, well, metastasized to your lungs, the spot doubled and you have multiple spots now. I says, so what's that mean? She says, well, with normal treatment, you have about a year. She started talking about these 2 clinical trials she had. And I mean, my mind wasn't thinking anything at that point. And she started talking PD-1 and T cells, and it was all, nothing was going in my ears at that point. So she kept on saying, this one trial I think we should push for. So she gave me a day to think about it. And at that point, I'm thinking, well, I wasn't thinking that the clinical trial was going to help me. I thought I was helping other people by testing out this drug for them. I would go in, they give me a blood test, start the infusion, and within a half hour, I was walking out the door. I had no different feelings at all. I felt normal when I came out. The only thing that changed is my thyroid slowed down, so they gave me medication for that, but that could have been caused from the radiation treatment too, so it was probably a mixture of both. Other than that, I had no other side effects on the drug at all. I've been off the drug now since last September. I was on it for 2 years, every 3 weeks. As of May, no evidence of disease. It's all gone. Ever since I've been feeling great, we've been, traveling a little more, camping a little more, enjoying life a little more. Back in 2010, my wife actually gave me a book, 1,000 Places You Need to Visit Before You Die. Now, this was all before my diagnosis, and we've been going through that book and checking them off. I think funding this research is very important because even the drug that I was on just didn't fix my cancer. It's fixing other types of cancers, and that's only one drug. Immunotherapy is a real breakthrough. I mean, they're so close to conquering this thing and keep the funding going, and let's get this thing knocked out of the way.
So we wanted to stimulate a discussion here with the panel, and so Dr. Lee's been quiet over there. We're going to bring her into the discussion. Pretty standard regimen, cetuximab radiation. Is this a typical experience for that regimen for HPV-positive disease?
Yeah, in terms of the reaction to with the rash, that's pretty common. Mucositis is pretty common. And as you know, the RTOG randomized study 1016 was still waiting to come out, but patients has the option of receive either cisplatin and cetuximab. And the accelerate fractionation is also pretty common when they give them either with cetuximab or cisplatin.
And so distant disease, not uncommon in an HPV-positive population, and the addition of cetuximab doesn't really address distant disease in that setting. So is this a kind of an immunotherapy candidate? Is this a common patient, Dr. Cohen, that you would see in your clinic?
Yeah, so very common to answer your question. I think you're alluding to some important points that are worth emphasizing. So first of all, the local control rates with standard therapies for HPV-positive head and neck cancer are excellent. And you're quite right, Bob. The major source of failure is unfortunately distant disease, and that essentially is for many patients incurable. So, and this patient went through exactly that course, good and maintained local regional control, but with failure in the most common site of distant disease, and that's the lung. Interestingly, if I'm following the timeline correctly, he would have failed within 6 months of receiving curative intent therapy. And there's, now, would he be a classic candidate? He certainly would be somebody who would fall under the approval of the anti-PD-1 antibodies, but he's also got some other things that are going for him with respect to immunotherapy. If I understood his rendition properly, he probably had a very low volume disease. And we're beginning to realize that patients with low volume disease may have a better response rate. He was HPV positive, and we shared your data about how that may be an influence in a positive direction. And I don't know his age, but he seemed like a fairly
54.
young man. He was 54.
Very young.
Yeah. Aren't you turning 54?
Not quite close.
But a young gentleman, and we're also beginning to make that association that perhaps younger patients have a better response rate. So I don't know if there is a classic candidate for immunotherapy, but he certainly had a few good things going for him.
And Dr. Lee, tell us about the hypothyroidism. Do you think that is primed by having radiotherapy, or is that related to cetuximab at all?
Standard chemoradiation and even radiation alone, there's a risk to hypothyroidism. The risk is dependent on your original volume of thyroid, but as well as the dose of the thyroid. If you have smaller thyroid, you're more likely to have hypothyroidism, and if you receive more dose and more volume of thyroid, you will likely receive that. But with the combination of hypothyroidism as a potential risk for toxicity from PD-1 therapy and radiation therapy, you hear that future trials would really monitor this much closely. Standard alone, you get about 40 to 60% risk of hypothyroidism with your standard chemoradiation or radiation cetuximab.
So for somebody with tonsil cancer, and as Dr. Cohen mentioned, a relatively low volume neck disease, if we can assume that, what would be the dose to the thyroid gland as opposed to, say, larynx cancer, where it's, in the way?
Well, it depends on whether we treat the neck ipsilaterally or bilaterally, right? Because again, if you have very low volume nodes and very low volume tumor, a lot of time we would do ipsilateral neck irradiation, and we spare the other side, and the risk is much lower. On the other hand, if you do bilateral neck and the lower neck receive around 45 to 50 gray, the dose of the thyroid, you're probably going to get around 40 to 50 grays.
So we know that the antibody we've used for 10 or 12 years, cetuximab, gave him very impressive side effects. Everyone saw that picture. But he pointed out that the anti-PD-1 was almost inert to him. He got up and walked away. So he has this thyroid issue. But is that the common adverse event profile, is to have a sort of asymptomatic hypothyroidism?
Absolutely. So again, in head and neck cancer patients, the two immune-related adverse events that we see more frequently are hypothyroidism and facial swelling. If you can call facial swelling immune-related, but those two events do appear to be higher in head and neck cancer patients. The rate of hypothyroidism is somewhere around 10%, maybe a little bit higher than that, maybe as high as 15%, as shown in the Keynote 40 study. But you're absolutely right, Bob. For most patients, it's not something that they detect because we're doing TSH on a regular basis. In fact, our standard is every time a patient gets an anti-PD-1, they get a TSH. Probably overkill, but we do it routinely so we don't forget to do it. In addition, they get a cortisol because you can see adrenal insufficiency. We get liver function tests because you can see hepatitis. We get creatinine, for all the same reasons. In a way, we've become rheumatologists, or at least we've learned to use steroids, and because we do see immune-related adverse events emerging.
Yeah, one thing I'd like to add is that, when you see a rash with cetuximab, you associate with good outcome, right? And we did a secondary analysis of our RTOG trial looking at that using 0522 and 0234. And interestingly enough, the people who have developed a grade 2 or higher rash who benefit the most of the HPV negative patient population. We see less benefit with the HPV positive patient population. Again, it's a hypothesis generating, and we'll see.
Great. Well, we want to stay on time and leave plenty of time for Dr. Quinn Lee. She, as you've already heard, is chair of radiation oncology at Stanford. She also chairs the head and neck committee of the RTOG, the NRG, and they've been leading the way with the combination of immunotherapy and radiation as a synergistic modality. Quinn?
Would like to talk a little bit about why we bring in immunotherapy and combine with chemoradiation in the locally advanced setting. I think this is the paper that came out from MD Anderson recently, and the question is there a prognostic significance to tumors that express high level of PD-L1? And it shows two big cohort of HPV negative patient population. The first one's a little bit over 100, and that was validated by a second cohort, again, a little bit over 100. And showing that if you have high protein expression, you have increased local regional failure, which leading to a decreased progression-free survival. And this was validated using an independent cohort of patients. So there's rationale that these tumors behave more aggressively, at least at the local regional setting. When you add anti-PD-1 or anti-PD-L1 antibody with radiation, you see that there's a synergism here in xenografts in terms of tumor growth delay. You also see what we call an abscopal effect. If you irradiate this tumor, you see the response synergism on the tumor on the contralateral flank that is not irradiated. And this is dependent on CD8 T cell, because if you deplete the CD8 T cell, this tumor growth delay is gone, and the hypothesis because you see increased MDSC into the tumor. So this is data from Chicago, and that kind of generate the interest in combining it with radiation. The question is it synergizing with anti-PD-1 or anti-PD-L1 blockade? And this data showing that regardless of whether you block PD-1 or you block the ligand, PD-L1, you see the synergism with radiation. And this is with fractionated radiation 2 grade times 5. You've seen the exciting data in metastatic setting. Now is the drug that improves survival in these patients. And I've been here for a long time, and I haven't seen a 1-year survival of 36% with single drug for any time. And so the question is, how can we benefit more patients who we treat with locally advanced setting? And I'll just mention some, unfortunately we don't have the mature data like Ezra Cohen show you. I would mention the trials are ongoing, and there's some potential toxicity related to that. But the trial in definitive setting, in high-risk post-op setting, with radiation alone, and hopefully to replace chemotherapy in cisplatin unfit or elderly patient, or also there's a discussion with replacing chemotherapy in good risk patient, with SBRT for recurrent metastatic setting, or in rare cancer in head and neck. I did this for AACR last year. I think this is probably going to be more than 17 trials listed on clinicaltrial.gov, focusing in head and neck cancer. And you can see this huge trial. These are big randomized trials looking at local regional advanced disease, stage 3, 4 disease. And the question is always the backbone of chemoradiation, plus minus an anti-PD-1 or anti-PD-L1 antibody. NRG RTOG, this trial is led by Dr. Ferris. There was a study led by Sanford showing that when you add pembrolizumab with chemoradiation, it was safe to do that, but that's a single institutional study. So the question we have is, can we do this in a big multi-center institution? So this is a phase 1 schema looking at different ways to add PD-1, this is nivolumab, with chemoradiation or radiation cetuximab, different backbone. One of them is with weekly cisplatin. The other one is with high-dose cisplatin. The third one is with radiation cetuximab. And the fourth one is in patients who are cisplatin unfit, and looking at nivolumab and radiation alone. And there's such enthusiasm. As soon as we opened this up, we filled up all the cohorts, and we're trying to finish up this cohort again. And we'll see, hopefully we'll have the data on toxicity and feasibility to present at the upcoming Arizona meeting regarding that. But as I mentioned, there are 3 different big ongoing locally advanced settings, all with high-dose cisplatin backbone. And one of them is with avelumab together with chemoradiation, followed by 1 year LBAC with avelumab. One of them with chemoradiation with nivolumab, and one of them is chemoradiation with pembrolizumab. They're exactly the same, and with 1 year of adjuvant treatment, and possibly more. So what about the post-op setting? I don't have the slide to show you, but Ravi Uppalari have shown in recent ASCO that when he treat more than 14 patients, but he presented if you take patient with locally advanced disease and you go to surgery, you give one single dose of pembro, you get about 40% pathologic response. That's with single dose of pembro when you look at surgery. So there's an interest to moving this type of approach in the both pre-surgical as well as post-surgical setting. So in the post-surgical setting, this is a phase 1 study through NRG Oncology. It's a multi-institutional study. We start out with patients with IMRT and cisplatin, and we add on pembrolizumab. We were actually planning 3 different cohorts, but we showed that adding the drug is actually well tolerated. We're waiting for any toxicity to come in, but this will be expanded into a much larger study, and then hopefully eventually that will be something that give a signal to whether we should push on for in the phase 3 setting. What about cisplatin unfit patient? We don't know what to do with these patients. You know, when we try to set up a trial, most of these patients do not make into the current trial. In NRG Oncology, 8% of the patient are age 70 or over, and most of them don't fit it. We don't have any cisplatin trials unfit because our backbone is always with cisplatin. So the question is, how can we work with this patient? So UNC has a phase 2 feasibility of pembro with radiation. The GORTEC has the study with radiation and pembro versus radiation cetuximab in the unfit patient. I'll show you the schema for NRG Oncology that hopefully will be activated in December. And then the REACH trial, which look at RT avelumab plus cetuximab versus RT cetuximab, and that's run through the GORTEC as well. So here's the NRG Oncology phase 2-3 trial. These are the patients with either elderly with poor performance status or comorbidity that preclude them from receiving cisplatin. All receive tumor biopsy. They have to be a little bit higher risk. So the good risk patient, they now stage 1, HACC version A oropharynx cancer don't get in here. But they are randomized to durvalumab plus radiation followed by backbone durvalumab versus cetuximab and radiation. This is a 444 patient study. It's a phase 2-3 because if everything looks good, we're gonna transition to phase 3, so keep the number of patients low in order to get the results sooner. What about reirradiation and the immunotherapy? And so there are many ways to do reirradiation, either with traditional fractionated approach or with an SBRT approach. This is a study that hopefully will be mounted soon through our TOG Foundation. It's called the Keystroke Study. And this is the first for real of us going to look at both SBRT and pembro, but these are the patients who are unresectable, who have local regional recurrence up in the head and neck area. So this is reirradiation setting. The standard for these patients right now is actually just reirradiation. It's unclear whether radiation with adding with anything else is better. So reirradiation versus, which is SBRT, versus pembro and SBRT. But essentially, we look at this as almost like a sequencing. If they fail the SBRT, they can actually proceed to pembro crossover. The primary endpoint is progression-free survival for these patients, and it's 100 patients that we hope to accrue. What about metastatic disease? Is there a role for that? And I think you've seen it at the clinical trial session at ASTRO, as well as the plenary session. These are lung cancer patients. We get chemotherapy, and then after 3 cycles of chemotherapy, they get randomized to either continue more chemotherapy or local therapy, which is mainly SBRT, to all the sites of metastatic disease. And this is the data that was published in Lancet Oncology from MD Anderson. And then the UT Southwestern just validate that with a smaller even cohort. There's a substantial improvement in progression-free survival from these patients from 4 months to 12 months of median progression-free survival, and the overall survival has not reached. So the question is, can we move this with immunotherapy, with SBRT? And so there's a few studies that are about to be randomized, mainly in lung cancer, but at this point, there's a lot of testing regarding fractionation and abscopal effect. And so we hope to solve these questions from Thomas Jefferson and MSK regarding fractionation, and then move on for head, neck, and other solid tumor. So what about clinical trial in planning state? There's an alliance with SBRT for Merkel cell tumor. And there's also mucosal melanoma, NRG Oncology, looking at PD-L1 and CTLA-4 blockade for mucosal melanoma from any subsite, including head, neck, GI, and GYN. So you've heard a little bit about immune adverse event from EDSA. You can have adverse event anywhere in the body. You can have liver, you can have renal, you can have skin, you can have endocrine, respiratory, GI, and neuromuscular. And all these is autoimmune related event. And so for these patients who are actually on these chemoradiation study, we check blood tests weekly, and we check a lot of blood tests. And hypothyroid, I mean, it may be overkill, but we're now doing weekly TSH at this point for these patients. And I just want to focus on two adverse event that radiation oncologists may have to deal with. The one of them is skin, and the other one is endocrine. And I think if you look at the data, it's very consistent between Pembro and Evo, about 8% endocrine adverse event. Most of them are thyroid-related event. The general principle of adverse event is diagnosis by exclusion. You need to recognize it early. Depending on the severe event, your management may involve steroids or other immunosuppressive treatment. If appropriate immunosuppressive treatment is used, patients are generally recover from adverse event, and the need for immunosuppressive therapy to manage AE does not appear to impact response, at least in melanoma world for CTLA-4. The general algorithm for grade 1, minimum or no symptomatic, you continue with immunotherapy. And if you have a rash, you treat the rash. For grade 2, mild to moderate symptom, you hold immunotherapy. You consider corticosteroid as the dose that's given here, and you redose if toxicity resolved to less than grade 1. For grade 3 or 4 AE, you discontinue immunotherapy. You hospitalize the patient, consider high-dose corticosteroid, and you taper the dose steroid for long duration, a little bit over than a month, until toxicity resolved to grade 1. If no improvement or progression, consider additional immunosuppression treatment. If more than 4 weeks of steroids or other immunosuppression needed, administer antimicrobial, antifungal prophylaxis to prevent opportunistic infection that relate to the steroid and immunosuppressions. So here's the skin toxicity. This is kind of a classic picture of what you see with skin toxicity with PD-1 therapy. You see about 15% rash, focal macular papilla appearance on the trunk, back, and extremity. It tends to be very low, grade 1 or 2. Severe is rare. I usually send folks to dermatology immediately. If grade 3 to 4, you do dermatology referral, IV steroid. As I mentioned, long taper. The one thing that we always worry about, and we do see with cetuximab quite a bit, is accentuation of infused skin reaction with radiation. It's unclear whether we'll see that with anti-PD-1 or anti-PD-L1 therapy, and we just have to learn more. Endocrinopathy, as we mentioned, 8% endocrinopathy, most commonly is hypothyroidism. I mentioned to you, radiation alone can lead to hypothyroid anywhere between 20 to 60% of the patient, average about 40%. The risk factor with hypothyroid induced by radiation is thyroid gland volume. As I mentioned, smaller the gland, more likely to have it. Dose of the thyroid, and the volume receive a higher dose, more than 30 grade. So again, it's unclear if radiation immunotherapy is additive or supra-additive on thyroid function, and so that's why we are very careful and monitor TSH regularly during combined treatment as well as in the adjuvant setting. And there's many unanswered questions regarding checkpoint inhibitors. My nightmare is that everything is great, and then we run these 600 patient trial and it became negative, and we really want to make sure that we understand radiation and fractionation is concurrent better than adjuvant. Will treatment, the notes affect treatment outcome? Is combination better than single therapy? And what mediate treatment resistance? So I think there's a lot of controversy in the field regarding big fraction versus fractionated treatment, which one's better. I think this is a very interesting study. This is a mouse study. You give a dose of 30 gray to the tumor in the mouse, you have increased survival. Now, if you give the same dose of 30 gray and then you add another 30 gray with fractionated dose, so now they get 60 gray, you actually have less tumor control with more tumor regrowth. And that's because there's a change when you give fractionated afterward. You actually see a change in profile. You see less CDA and you see more MDSC. These bad macrophages go to the tumor. So this is the argument against fractionated radiation therapy. But if you look out there, the regimen from preclinical study looking at all these immune checkpoint therapy with radiation, it ranges anywhere between big fractions to tiny little fraction, like 2 grays. A lot of them is giving afterward. So it's really unclear what dose we should give. If you look at Silvia Fomenti data in terms of abscopal effect, her dose to give metastatic disease less than 3 grade, and this is in Lancet Oncology. You have the waterfall plot response in abscopal effect. Outside is actually with smaller dose, and with GM-CSF. So there's 2 camp out there. One camp said, oh, you can't get away with fractionated, you should have big fraction. And the other camp said, you may be able to. Her data also show if you give 20 gray of radiation, you have less response, but if you give 8 grade times 3 or 6 grade times 5, you actually have better response in these tumors. So I'm actually stuck. I can't tell you what dose to give to patient right now, but what we need to do is when we do these big trial of 600 patients, we actually should learn it from our patient. And one of the things that people have done is they look at fractionated radiotherapy, T cell and immune cells. With the fractionated radiation, you see increasing T cell with allergic phenotype at the end of the fractionation. So we really want to make sure that if we do that, we've learned how to give the checkpoint therapy in the right way. With fractionated radiation, we do increase T cell energy, but then we may say, well, maybe that's the way why we have to give PD-1 because it decreases the energy. I can't tell whether that's the case. What about concurrent versus adjuvant? So here's a study in mice, fractionated radiation from Davidi in UK. They give the PD-1 therapy either before the fractionation, at the end of the fractionation, or after the fractionation is done. And they show that if they give it together, you actually have better tumor control and more mice survival comparing to at the end. Bob Ferris also have done that study where they give no treatment, PD-1 alone, RT alone, or when you give concurrent, sequential, and the loading dose. It looks like when you give it before, during, and after, it seems to be the best for these studies. So that's why all these human study based on preclinical data, everybody get a loading dose, then they get the treatment during therapy, and then adjuvant afterward. But it all depends on what type of immune checkpoint therapy, right? So here's CTLA-4, immune checkpoint therapy. If you give them during day 7 of radiation, you have the best. But if you give an OX40, which is activator, given after radiation may be better. So again, the type of sequencing depends on what type of immune therapy you're giving. Do we have any data in human? Fortunately, we don't have any data in human for PD-1. Here's a human data for melanoma, for brain metastases. If they give concurrent with the radiation versus non-concurrent with the radiation, the concurrent have a better decrease in tumor volume than non-concurrent. And if you give concurrent, you actually have a little bit better survival. This is retrospective, small single study. The Parker Institute is trying to put together a big cohort of all these registry to see whether we can learn from these patients that get radiation and checkpoint therapy. I've got to highlight Dr. Fair's trial, so that's the question that they're asking. They're asking whether they give concurrent chemoradiation with weekly cisplatin, with pembro at the end versus pembro during, and weekly cisplatin, do you see better early efficacy data? This is about 44 patients. We have 22 accrued, so hopefully we'll learn from Bob real soon about this. Okay. Finally, the next question, I've always wondered why we treat all these lymph nodes in the head and neck. And then if we treat all these lymph nodes in the head and neck, do we actually decrease the efficacy of immunotherapy? And this is a really nice study, preclinical study that nobody ever quoted. So if you take the mouse and you give the radiation and you take the lymph node out, and then the question is, if you take the lymph node out, does it affect the radiation outcome? And so you can see here, if you take the lymph node out, the radiation efficacy decrease. And the same thing here, they have an animal model where they ablate the node. You can see that when you ablate the node, you lose the efficacy of the radiation. So it's interesting, and this is a Cell paper that came out from Ed Engelman lab from Stanford, looking at PD-1 therapy and CTLA-4 therapy. And everybody's thought was, CTLA-4 is priming the lymph node, and the PD-1 is priming the tumor cell. He actually showed that you need the priming effect occur distal in the bone marrow, in the blood, in the spleen, and in the node. And you need all these responses in order to get the best activity out of PD-1 therapy. So it's not just the local tumor that's priming, but you need priming of all the distant site. So going back to University of Chicago again, so this is the question is, can we be smarter in treating the node? And so what they do is they give induction chemotherapy, and then in those who have a complete response, they actually treat the tumor site only. And in those who have partial response, they actually treat the primary site plus the regional node. And if you look at that, this is pretty gutsy. You just treat the tumors alone with margin for partial or complete response. And you can see that they have not seen an increase in local regional relapse in these patients. So progression-free survival for HPV positive is quite high, and HPV negative. And then if you look at a patient with good response and non-response, they do quite well. So this is something that people are starting to explore. Can we reduce the few sites in head and neck cancer? And that's what we hope to explore in our next generation in NRG Oncology. Finally, radiation combination immunotherapy may be better, and you've heard why people are heading toward combination immunotherapy in metastatic setting. Andy Min has shown that resistance to CTLA-4 is because of PD-L1. And if you combine PD-L1 and anti-CTLA-4, you actually have better outcome in mice, and that's also very similar to the small study that they did at Penn. So this is rationale for looking at more combination in the earlier setting as well. At Stanford, we've also looked at AXL in relation to a response to drugs, and we show that when you combine targeting AXL with anti-PD-1 and anti-CTLA-4 treatment, you have much better outcome. And there's rationale behind that, which I don't have time to go through, but this is where you see new combination come in both metastatic and early setting. I just want to conclude that I think immune checkpoint therapy, especially those that inhibit the PD-1 pathway, does improve survival in patients with metastatic head and neck cancer. There are many questions that remain, and I think we need all of you to help out to address these questions by putting these patients onto the trials and help us to address these questions. Does adding immunotherapy to chemoradiation improve survival in non-metastatic setting? Can immunotherapy replace chemotherapy in certain setting? Are there unanticipated toxicity when it's added to the standard treatment? And what are the optimal dose, fractionation, fuse size in locally advanced head and neck cancer? And without putting patients on the trials, we can't answer these questions. Thank you.
We have the ability here to answer some of your iPad questions before it gets too late. We want to try to group them together. One question would be, Dr. Lee discussed reirradiation. So here's a question. Would you test for the question is PD-1, but I think the question is about PD-L1. Should we use that in the recurrent metastatic setting? So Dr. Cohen mentioned that there is still a response that favors anti-PD-1 when PD-L1 is negative. One of the things one needs to know is that the tumor can be PD-L1 negative, and there can also be immune inflammatory cells that are detectable by the same immunohistochemistry. And so you can have PD-L1 in the microenvironment even if it's not expressed on the tumor cell. So that's why we don't want to be restricted to only treating patients who have PD-L1 in the tumor, because you can also have PD-L1 in the inflammatory cells. And in fact, even when they're both negative, occasionally we see some benefit. So in head and neck cancer, we don't test for PD-L1. Clearly, if you are PD-L1 high, there's a better response rate. So it's not to say that PD-L1 doesn't enrich for responses. Dr. Cohen, you have a comment there?
So I completely agree with you, Bob, that it's not indicated, even the PD-L1 negative patients, or in other words, all comers do appear to have a benefit from anti-PD-1 therapy. So if it's not going to make a difference in your management, then why do the test? That might be different going forward as we get into first line and as we get into locally advanced disease. And the bar, in a sense, gets a little bit higher because the standard therapy is a bit more effective. We may begin testing for PD-L1. We saw that in lung cancer. It was the PD-L1 high population, greater than 50%, that had a benefit over chemotherapy in first-line lung cancer. We may see the same in head and neck. Obviously, those stories have to play out. But right now, no indication to test for PD-L1.
A couple quick questions. Are there studies recruiting for radiation IO trials outside the U.S.? Absolutely. There are a number of companies that co-market some of these agents, both in Europe as well as the U.S. and Asia. So those are recruiting quite avidly outside the U.S. Any role for immunotherapy with the Bonner cetuximab radiation regimen? Yes, I think the REACH study was pointed out, and then so there are a series of PD-1 with cetuximab RT or PD-L1. Those studies are also open and accruing. Does immunocompetence correlate with response? There is some data that has been presented that a higher fraction of CD8 positive cells in the circulation may represent an immunocompetent patient who can respond. But another question about, are there blood biomarkers? I think that's an emerging area. Most people feel like the best biomarkers are in the tumor. That's where those neoadjuvant trials that get pre and post specimens may be most informative, but there is some early data coming about from the blood and some cellular phenotypes. Then there's a question that I think probably is best for Dr. Lee, but the questioner wants to direct it to Cohen and Ferris, but maybe they know what Dr. Lee thinks. What do you think about the future of radiotherapy for head and neck cancers in the era of immunotherapy? So we are aware that we are at Astro, and so I'm very in favor of radiation therapy. I want everyone to know that. I want to make it out the door in the back. No, I think Dr. Lee actually pointed out that we're likely to try to harness the beneficial effects of radiation therapy to induce DNA damage, the inflammatory signatures and danger signals to induce antigen transfer to the immune system, and to the extent that we can harness those beneficial effects of radiation therapy without some of the more chronic adverse events when we get up to 60 to 70 gray, then I think it marries quite nicely with IO therapy, and that is really where the RTOG is starting to really apply it. Is in the high-risk group, we're uncomfortable backing off at present, but eventually I think we're going to get to where we're comfortable enough with the benefit of adding immunotherapy that radiation can now begin to be modulated down with field size and dose intensity.
Yeah, I agree 100%. I mean, can you imagine if we can just treat the patient like Hodgkin disease dose or 2 grade times 2, and then, you know, they have no toxicity. We can treat at many sites if you need to in order to take care of the tumor, and you can turn metastatic into non-metastatic setting, right? Bring in radiation therapy as a systemic treatment.
Dr. Cohen, can you answer this one? Does severity of the immune-related adverse event correlate with efficacy?
There's some data emerging in melanoma that might be true. Larger data sets, and so it's allowed us to do those types of analyses. I'm not aware that outside of melanoma that there is a strong correlation. In fact, even the correlation in melanoma is not that strong. So there probably is a relationship, but it's not a very strong relationship.
I think we've answered, one question. Without mature phase 3 data, is it acceptable to give concurrent radiation plus PD-1 inhibitors? I would say it's premature given that we have FDA-approved agents, either cetuximab RT or cisplatin RT. I'm not sure it would be covered, and only in where the standard of care is radiation alone, where one might get away with excluding a more proven systemic therapy.
I do think you need mature data because, for example, everybody thought cisplatin is effective against head and neck cancer, cetuximab is effective against head and neck cancer. Everyone was betting for sure when you combine the two of them together, radiation, you're going to have much more effectiveness, and we prove it wrong with RTOG 0522. And I think, and sometimes you can actually prove it going the wrong way, which is they can actually do worse. So I really would caution against rapid application.
Yeah, so can't overemphasize that, and we've been wrong in the past, believe it or not, and these trials may not only prove to be not positive, but they actually may be negative. We don't know that yet, and until we have more mature data, I would not do this outside of a clinical trial.
Again, I'd like to thank PeerView for organizing this, and thanks to all of you for being here. Thanks to our panelists.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/RBS. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated.